and go ahead and get started. I want to welcome you to our bariatric surgery webinar tonight. We've got lots of good things in store for you. Just a reminder, we have a Q&A box. If you have questions, we're going to have plenty of time to answer those at the end of the webinar. So pay close attention. There's going to be a few questions at the end, and the winners to those questions will get a Publix gift card. I'll start off with some introductions. My name is Angie Bunkley. I'm our Bariatric Surgery Program Coordinator. We have speaking tonight Mr. Greg Laffitte. He's one of our bariatric PAs with the program, and also Dr. James Parker, one of our bariatric surgeons. I'm going to go ahead and let Greg take it away.
Thank you very much, Angie. Okay, I hope that the communication component to all of this is going to take care of everybody. Welcome. It is a Thursday night. I can't think of a better place to be to talk about your health. I hope that you might take an opportunity to get some of your family members to join you. It'd even be a good idea to get a sheet of paper and a pencil in the event that you have some questions. If you could jot these down, and as we progress through this presentation this evening, you'll be able to go back and reference those. The program that I'm going to present to you tonight is very, very comprehensive in nature. And so there may be even some questions that you might have that, or some points that you'd like for us to address that we don't bring up. So please don't be bashful. So without further ado, let's jump into this. I'm not a big proponent of reading PowerPoint slides to you. I think that's well spoken that most folks can read these things, but I'm going to capture the essence of these. I'll spend the time in the places that it's warranted, and then I'll move rather quickly to those subjects that deserve a certain amount of attention. We are going to talk about the team that we have here, of course, and the personalities of the people that have specific job duties and responsibilities. I'll go through that. I'm going to go through the definition of obesity for sure, challenges, and a couple other things about that. So let's get this thing started. That's the team. It's important to know from the get-go that your care is extremely important to us, and that the manner in which we accomplish our mission set is to take care of you. And it does no good if we don't work as a team. We've got a bariatrician, dietitian. I'll go through each of the names or the definitions of what these people do so that you have, I think, a more comprehensive understanding of how we're going to take care of you. So right off the bat, and I think it's well worth mentioning that we're going to brag on ourselves a little bit, simply because this is where the patient benefits. We use a bariatrician, which is that practitioner that specializes in treating obesity. We treat the obesity itself. We also treat obesity-related diseases, the other problems that you may be experiencing because of having obesity for a number of years. And we go into the details with regard to either medical, non-surgical weight management, and we can also, of course, do surgery, which is why you're here tonight. So when you hear the term bariatrician, physician assistant, this is the name of that individual that's going to be specializing in your care and guiding you through this particular journey. Next slide gets into who the bariatricians are here. We have a medical director, of course, that's me on the left, and we've got Brandy Thompson. Brandy is a fantastic addition to this team, in addition to the actual support team of dietitians, which these gals, when you get a chance to meet with them, second to none in terms of their skill set. They're very, very well versed, very, very easy to talk to. And collectively, I think you have just a rather enjoyable experience meeting with us as you begin that journey. So think of this as a team approach. That's extremely important to understand because we work together and discuss back and forth with regard to what your care is. Your surgical team, that's why you're here tonight. Dr. Parker is with me tonight. We'll be giving that presentation. We got Dr. Joey Gerard. Megan Bell's the PA, of course, in here, and as well as Courtney Roush. Again, the addition of very skilled, passionate, and competent people that are that team that take care of you from the beginning of this and then in the years to come. No program goes forward without the stellar sage leadership and accomplishments of Angie Bunkley. And she started this journey off tonight. She's been communicating with you, and she'll be able to provide contact information for you guys at the conclusion of this presentation. This is a great, big, important discussion that we're going to now have. And I'd love for you to take out a pencil and kind of keep track on these things because it probably will satisfy some curiosity and some concerns. So what do? Why come see me? Why come see anybody at the Bariatric Center? And the reason why is because we want you to be able to have a clear understanding, to be able to comprehend what your medical challenges may be, so that you understand metabolic, medical, the relationship of perhaps why the obesity has been a problem for you, and to kind of get a little bit of a grasp on how do we move forward with this. It's extremely important, I think, that you appreciate the fact that we do a very, very, very good job of listening to you. We do not have a one-size-fits-all philosophy. You're going to find the interaction in this place, either here or over at the hospital, to be very, you're going to feel safe with us. There's no judgment. We're trying to uncover metabolic challenges and medical causes, and we'll spend a lot of time to be able to get to the root of that, root answer to that. There's a concern possibly of habits. We're not judgmental, and we're trying to have a clear understanding. If there's any eating disorders, we'll have you in front of a counselor to be able to address that and then to move you forward so you can have a long-term success. One of the challenges that I find myself enjoying really is to basically go into your medical file. And we have a software system that allows us to see a lot about you. And something that's extremely important with this is the reviewing of the medications that you take. And strangely enough, there may be those that you're currently taking that may inhibit or even slow down your ability to lose weight. I want to uncover that. We'll do lab work on you to make assessments for diabetic status, thyroid, to mention a couple. We'll have conversations about it's a better idea to do this behavior as opposed to that. Good conversation about nutritional habits, trying to shape you so that at the end of this process, meaning we're now going to the operating room, when you recover and it's time to go home, we want you to be in that place where your recovery is something that's going to feel very, very familiar. And so the conversation with your dietitians, with a therapist, lead us down that path, I think, for overall success. A lot of confusion can be found if you search the internet or talk to friends and family about, well, this diet does this diet does that. Leave it to our professionals, I think, to give you the best information and to educate you in the direction that we know is proven to give you long-term success. It's our job to make sure that you are, and your families are going to be involved with this, of course, as well. But we want you to be as healthy and ready to go with this as you possibly can, so that you can then undergo that surgery and then have a lot to look forward to in these years to come. I think that it's always something that people enjoy, of being able to share the experience, whether they've gone on a vacation, whether they've gone to a party, whether their child's going to have a dance recital. We like to share information. Well, sharing information here in this place has the tone, a little bit of accountability. And I think it's well worth mentioning that those individuals that come in that are ready to do this, if they're a little bit of an open book and your dietitian says, I'd like to see what your habits are. When your dietitian says a log book to look at the calories, that's really good. If I ask the questions, have we started getting some exercise? We help you with success by sharing that story, essentially keeping you accountable for things. I love the idea about the discussion of nutrition. And people begin to find out, I really did not know that I had the habits that were working so hard against me. So accountability, communication, a team that basically addresses all of these concerns helps you not only before, but certainly after the surgery. This slide seems somewhat busy, so I want to draw your attention to just a few words, if I may. You've probably never had someone in your healthcare experience refer to obesity as a disease. And I think that should give you some pause to reflect and maybe not quite feel bad or as guilty or whatever negative connotation you think you might have been experiencing, because we here at the Bariatric Center and our surgeons, we view this as a disease. And once it gets started, it's extremely difficult to be able to treat. It's a chronic disease. It relapses. There's many factors that are associated with the obesity and the problem with the accumulation of fat and the unhealthy fat that's in the body. So we want to be as clear as we can. we're not dealing with just you need to stop doing this particular behavior and start doing something else. It goes far deeper than that. The definition of this, very busy slide. Your insurance company is more concerned about this from the standpoint of qualifying you for surgery. Now, the term BMI is the principal document, or at least a number that we will use to give you a reference point. And when you find someone that has an obesity or a BMI that's a 30 to 34.9, those individuals are typically not qualified for gastric surgery, and your insurance company is not going to extend that coverage. But when you get into the realm of a 35 at the bottom of this page, you see a 35 to 39.9, you must have at least one comorbidity in order to be qualified for the gastric surgery. If you have a BMI that's greater than 40, then these comorbidities are not necessary. It's important, I think, recognize when you come and you see us, we will go through your medical chart to determine where you fall on this scale for the BMI. Pardon me for a second while I get a drink of water. I'm sure that you've had some family members or friends or people that may be just very, very, just acquaintances maybe at work. And you might have had someone that has a negative idea about what you might be attempting to do. First off, people are allowed to have their opinions, but let's talk facts. It used to be that obesity was perceived, and I'm reading this, but this is quite salient. They would look at someone and say, well, that's because you're weak, or you can't stick with discipline, you have failed. It's your fault. They're basically pointing a finger at you and saying it's your fault to do this. You only relied upon diet or exercise and thought that that was the way to be able to get healthy. And in many instances, there were people that would look at as generally as surgery as being dangerous. And that's the before piece. The reality of it is obesity is a disease, and it's the cause of a lot of serious health conditions. And truth be told, surgery is an extremely effective and a very, very safe tool for weight loss. Of interest as well, less than 1% of all eligible candidates for gastric surgery are ever referred here by their primary care provider. I find that astonishing. Let's take a second. Let's go back and visit this again, because when you come here, as I mentioned, our team is going to take care of you, and we want you to feel like you walk in the door, they get it, they listen, they care. There's some compassion with this, because we throw out this business of, oh, that's because they didn't do what they were supposed to. Not a fair way to assess us. I want you to look at this and understand that we recognize it as a disease. It causes a lot of problems. Let's pause for a second and think about two words: your health span versus your lifespan. If you've ever witnessed in your growing up years, maybe a classmate, next door neighbor, where you've seen someone who all of a sudden has, at a specific age, let's throw the number 60 out there. They're 60 years of age, they have a heart attack, they find themselves in the emergency room, they find themselves spending a period of time in a coronary care unit, then they may go to a coronary rehab unit, and then they go home and they stay in a wheelchair and they never get out of it. Well, that's where your lifespan has now been challenged, and certainly your health span has been compromised. Our job is to keep that lifespan going way out, but more importantly, that health span. I spoke with a young lady late this afternoon, and I asked her, what is it that you want to do? She told me she wants to go on vacation wherever there's water. She wants to go down into the Caribbean and sail a boat. She'd like to go to St. Tropez, different places. But it was the essence of an emotion that says, I don't want to be in a nursing home. I don't want to be a burden to my family. I'd like to go out and live a happy, full life. That's why you're here tonight, because surgery extends that health span and helps to defeat these bad players that show up with obesity. I cannot overemphasize that. Any time I've ever had a family member that I went to visit in a nursing home, in the vast majority of the time I went in there, I look at this as an environment. I don't ever want to be here. How do I do what I can to make sure that that's not where I end up? Next subject. This is pretty interesting as well. Fat is a gland. Think about your glands. We've had a lot of pollen in the air, sore throat, tonsils, tonsillitis, whatever you may think of. But it's this big gland in the body. And the bad thing about this gland is that it makes these hormones. So we talk about chemicals more scientifically, inflammatory factors. Google this on a YouTube channel. You find more than you ever hope to read. But if we can eliminate central obesity and get it to cause the heart attack risk to go away, the strokes, diabetes, joint pain. Think about if you're carrying 100 pounds or more, what that added pressure is doing to your joints. And other inflammation, of course, with this one. So we're talking central obesity. We're talking a BMI of 35 or greater with one comorbidity or more, BMI of 40 with maybe multiple. You might even have a medication list that's got, I don't know, something for your blood pressure, something for your diabetes, something for your cholesterol. You might even be on a CPAP device. And you may be in this place and say, I think I can do a pretty good job of watching what I eat, but my knees bother me so much I can't get out and perform this exercise routine. Well, you probably are one of these ideal candidates to be able to have a gastric surgery that would basically be a way of helping you get to the next place. So central obesity, remember, a great big gland causing problems. We want to get rid of that big gland. You can't pick your family. You can't pick your parents. Mom and dad have health problems. You probably should get on the phone tonight and call and say, hey, Mom, what medications do you take? And get a sharp number 2 pencil. Write that down. Dad, what do you do? What were my grandparents? What was their health history? Your brothers and your sisters. Try to have a clear understanding of what that family. Now, every time you go check in an office somewhere, you're being asked to fill out this form that says, well, what is my family history? And most people blow that away, blow it off. And in this case, these are the factors that you want to be aware of. And why is that important to be aware of it? Because if they had it, there's a very strong possibility you may be inheriting the same thing. Ethnicity. We know that certain cultures, family habits, social structures play a great big role with this, the ethnicity, if you will. The genetic predisposition of, well, I'm a Samoan, perhaps, as an example I can give there. Or people have always told me I was big boned. It's something to be as much aware of as I think as you possibly can. How about medical causes? I know for a fact I can tell you that a lot of ladies will come in and they say, well, yeah, I've had PCOS since I was a preteen, having a hard time having children. Oh, but by the way, before I forget to say this, weight loss surgery, you better get on a birth control pill or a form of contraception, because within a span of time, if you've been having a hard time with having kids, you can have children. We see it every time. So the PCOS, it's a hormonal kind of a thing. Stress. COVID, for example. People went through a lot of stress during COVID. I hear people all the time describe that they are an emotional eater. Been taking care of my mom, been taking care of my dad. I don't get to take care of myself. I don't get to go work out. I've got 3 kids. One's at a soccer field, one's at dance class, and the other one has to get to his part-time job at McDonald's. So parents, generally speaking, in terms of taking care of other people, their care and attention gets compromised. So that business of trying to go to the gym, I can't tell you how many people have a membership at Planet Fitness and never go. One lady had a membership there for 10 years, only went one time. Lack of physical activity. We don't use the machines like we used to. I sit all day at a computer other than getting up and going back and forth down a hall. Environment. This is a big one. I can order Jimmy John's, I've got DoorDash, Uber Eats, you name it. So it makes it very convenient. So in the context of why is that problematic, other than the obvious reason, is you get home and you're tired, and instead of, all right, dietitian told me to grill some chicken. It's 7 o'clock at night. We just walked in the house. Now I'm going to start grilling chicken. No, I don't think so. We're going to get our grilled chicken by going through Chick-fil-A. So these are a number of factors, some of which we can change, some of which we can't. As I mentioned, you can't pick your parents. I'm reminded of this challenge every day, and that is people that come in and they're exasperated with their health. They remark on when they were 8 years old, there were no challenges, maybe 18. Go a little bit further down the pike, finish high school. Some guys go out and join the military. Some people go to college, and they find themselves in the years to come, say 20 years goes by and they add 100 pounds. And there was a time when they were very healthy. They didn't have a medication chest full of different pills. But now they find themselves, because the obesity has taken hold, with a number of challenges. And I say these as risk. The other night, we had a bad storm that came through down towards Wakulla County. And I was down measuring an area where I want to ride my bike. And there's a guy on Highway 98 pulling an RV, and he was passing someone and could not get around them. So he was head on at me in my lane. And if I hadn't pulled over to the side, I'd have gotten hit. So there's a risk that's associated with day-to-day activities. Wear your seatbelt, wear a helmet, don't skateboard, do smart things. There's a risk associated with obesity. And when you come and you get involved with our team, obviously you know about it already, but our job is to say, if we are successful with this, look at this list in front of you that we can deal with. Cardiovascular disease. Okay. Some of you all tonight are watching this, you're taking statins. Diabetes. Some of y'all are looking for the wonder miracle drugs of these injections. And a comment briefly about that. Those drugs are new. Some of them have phenomenal results and long-lasting success. Oh, that word long-lasting. They've not been out really long enough for us to have a real certain understanding of what's going to happen. When you discuss gastric surgery, on the other hand, I know, I've seen it, we track it. And you've got a professional team of surgeons that can say, if you follow this protocol, if you do these things, if you change your life in this fashion, we want to get you off of medications instead of adding medications. It's important as it can be. And then you're going to be drawn into the chance of buying some compounded stuff that's on a street corner and you don't have any idea where it came from. So enough about this, other than just to remind you, obesity is not just what you see in the mirror. It's not just what you see on the set of scales. It's what's going on beneath the surface. The measurement of blood values, CBC, CMP, vitamin D, thyroid. How about a hemoglobin A1C? And then we go, all right, we're going to have these surgeries. What are we going to do about the nutritional status? We're going to watch that stuff. More to come on that one. I was in Disney World with grandkids 3 months ago. And other than the fact that place was as expensive as it can be, I was astounded at the number of people that are now in motorized buggies. And they have in one hand a cotton candy and another hand a big thing of popcorn looking for the hot dog stand. I'm not being judgmental about that, but that's a society that we live in that's turned this into the highest obesity rates we've ever witnessed. Now that number is, this is 2025, so that number is 7 years old. I think that number 42.4 probably has gone a little bit north. So whether there's any make you feel better about it, there's a lot of folks out there that are suffering with the same challenges. But the good news is that tonight you are here listening to this presentation and we have an answer for you. 100 million, busy slide. Let's keep going. As a former military guy, I pride myself in basically having strategic visions. I like goals. I go, well, if I'm going to do this, then I want that to happen. If I go fishing, I hope that I catch some fish. If FSU plays a football game, I hope they win a game. That's not worked out so well for us recently. But when you come and work with the TMH team, how you like that pun? Overall management goal. You show up, we've got the obesity. Our job, 1, 2, 3. I want your health to get better. I want your quality of life to get better. Body weight and composition. You will start lifting weights. The combination of those 3 points on the right-hand side of your screen should get you very excited. When I have an 81-year-old lady, 81-year young, yeah, she now is out on cruise ships with her girlfriends, traveling the world. When I see a young gal that's a nurse over in Chattahoochee that has suffered and had a very tragic upbringing, but has been able to overcome so many challenges in her life, go from 400 pounds to under 200, and these are real people. When I see a lady that we've taken care of for years, that the next time she follows up, she's not with a walker, or she tells me she can stand on one foot without falling over, or she can get on the floor and play with the grandkids and get up. Or now, and at Christmas, I remember I got a postcard from a lady that was in Italy. She was traveling. And so you have to consider, are you that person that says, I've done everything I can and nobody's ever listened to me? Well, that all changes tonight. Game on. Get your health better, make you happy. And for the ladies out there, I know men, we're a little different, but I can assure you there's a sensitivity to this that you go, I don't like the way I feel. I don't like the way I look. My health is not what it used to be. Well, you've come to the place here now because our goal is to help change all that for you. And we're pretty good at it. We're very good at it. What can it do? Now I'm going to use round numbers. The surgery can be, and that much of this, if you go to school and you don't study, or if you skip school and go smoke cigarettes and play pool in a pool hall somewhere, you're probably not going to do real good in school. If you come to the surgery center, the bariatric world, and you apply yourself, excuse me, and you listen to the instruction that our professionals are providing, excuse me, you stand to lose a lot of weight. Now, we're going to play a little bit of a numbers game, but I'm going to keep it very simple. Let's say, for example, when you were 18 years of age, you weighed 150 pounds. Let's say you're 5'4", you got 150 pounds in there. You're going to be having a BMI that's close to 25. We can check the numbers. But 20 years goes by. You've been married. You got these 3 kids. You've been working a job someplace. And a lot of you taking care of you has gone away because you're taking care of your family. And you might even have aging parents that are now part of the factor. So let's just go for the example of we put on 100 pounds. And we want to get that 100 pounds away because now, oh, hey, now I'm a pre-diabetic. And all my friends are telling me that I need to do something about it. And we've got this 100 pounds that we want to get rid of. With a surgery like this, the way the numbers work is we look at this and we describe this as excess weight. I'm going to back that up. I'll leave it there. I mean, the point is, if the excess weight with the vast majority of the surgical cases, you can generally count on losing about 70% of that. So if you get that 100 pounds overweight or more, 70 out of 100, that's a great number. And I've seen that change people's lives. Now, are you a candidate? And y'all are now going to be taking notes about this, I hope. Mention this again. It's a BMI greater than 35. BMI greater than 35. And you can actually go on the internet, and there are BMI calculators. You can put your height, put your weight in there, and give you an idea of where you stand with this one. We're going to accomplish the same numbers when you come here. So you've got to be BMI 35 with a comorbidity, at least one: high blood pressure, diabetes, high cholesterol, sleep apnea. At least one of those. If the BMI is 40 or greater, you don't have to have a comorbidity. The next one, it's important to understand you've got to be able to undergo a major operation. And our screening efforts, particularly those over at the surgery office where Dr. Gerard and Dr. Parker are, their staff will be reviewing your records to make the determination about whether we need to get a cardiac clearance. You might need a pulmonology clearance. And also, and this is a big time important, failed attempts. You've done everything you can. You've tried walking from here to Atlanta. You've been eating dust for the last 15 years and nothing changes. Yeah, that's a big one. Alcohol, or the drug and the alcohol problem. And if some of those have been part of the past, you notice it says absence. We'll work with you on this one. No uncontrolled psychological conditions. We all look at it as a team. And then you're going to have a very, very thorough evaluation by your surgeon to help you understand what those risks are, to understand what the surgery is and what the risks are. And I'm getting ready to switch over here to Dr. Parker because he's going to take this with regard to moving forward into the surgery thing. So before I hand it over, and then we'll close out on a couple of things. I have been witness to people who have been frustrated. This coming May, 9 years, been a PA over 35. So next year I've been here at TMH Bariatric Center, come up 10 years. And I've had, no kidding, in between the follow-up visits, the new visits, 10,000 cases. And I can think of no other effective way for definitive action to help you achieve your long-term health goal. So we're going to revisit 3 primary points. Number 1, we want you healthy. Number 2, how do we do that? We're talking tonight about gastric surgery. And if you do your research, you will find that less than 1% of eligible people have ever had this discussed or suggested by their primary care provider. Third point down at the bottom, follow up. You don't just have this surgery and disappear. I want to see you again. Your surgeon wants to follow up with you. We want there to be a relationship where you trust us to give you the very, very best care that you possibly can receive, so that 5 years, 10 years down the road, you've been able to sustain let's getting healthy. And that means I'm going to have a problem with people in their 70s, in their 80s, and early 90s riding roller skates on the St. Mark's Trail while I'm trying to ride my bike when I'm 105. So these are big things. It's been a privilege and I think a pleasure to get a chance, although one way, to offer this information to you. And I hope that you seriously, seriously consider, come up, give us a shot. Let's talk about this and give you the information to help you make a very comfortable, sound, educated decision about what your health is going to look like moving forward. And with that, I'll turn this over to Dr. Parker.
Appreciate it, Greg. Computer. Hi, I'm Dr. Parker. I'm one of 2 bariatric fellowship trained surgeons we have at TMH. My partner, Dr. Gerard, and I did the same fellowship at St. Luke's in Kansas City, which is regarded as one of the top programs in the country. So we got a good education there. And because we train at the same program, we do things the same way, which is pretty nice for a bariatric program to have all the surgeons doing everything the same way. And so at TMH, we have a few options for weight loss surgery. The first, and these are the different types of approaches. The first is a restrictive approach, and that's basically just decreasing the amount of food that people can take in at a single setting. The gastric band is no longer in favor. 99% of programs spend their time taking out bands, but don't offer placing bands anymore. And basically what that did was there was a band that just went around the top of the stomach, and that just prevented anybody from eating a big bite of anything solid. And so very, very tiny bites and fluids are really all that could go down, and that could be restricted by inflating a band. But what we found was that people would regain their weight after a couple of years. It did a great job for the first couple of years at helping people lose weight, but people began to learn how to take in their calories in alternate fashion. So drinking Mountain Dews and getting their calories through carbohydrates in liquid form is why they gained weight. Typically, we like to remove those bands now and either offer a sleeve or a bypass. So gastric sleeve is the most popular of the restrictive surgeries. About 80% of bariatric surgery nationally right now is the gastric sleeve, and that's for good reason, because it's been around since the early 90s, but it really wasn't used primarily as weight loss surgery until the late 2000s, when people realized that people who were getting cancer surgeries, removing part of their stomach, were actually losing a lot of weight. And so now it's really taken over the band as the most popular restrictive bariatric surgery. Basically, we just staple straight up the stomach and turn it into a smaller pouch, tube-like structure that basically allows us at the end of the day to take in about a third of our calories and prevents us from getting hungry and craving foods. And then there's the malabsorptive procedures, which The first is a biliopancreatic diversion with duodenal switch, which involves a sleeve, but also a very long bypass. This is offered selectively at TMH. We've only done a couple here, and it's not very common nationally because the sleeve is so popular, and people do generally lose about as much weight as they'll be able to lose with just the sleeve alone. And there's the combination procedure, which a gastric bypass restricts the gastric pouch to about 2 ounces, or a little bit bigger than a shot glass. And then it also reroutes the intestines to where we bypass the beginning of the intestine to decrease some of the caloric absorption. So it works in 2 ways to help patients lose weight and get healthier. So this is the gastric bypass. So basically, it takes the top part of the stomach and turns it into a little pouch and hooks it up to the intestines, where it's able to allow food to come down and then not start getting digested until it meets up with the digestive juices downstream. And then in this common channel is where patients are able to start absorbing their calories and nutrients and everything. And this is the sleeve gastrectomy that I talked about, where basically we just staple straight up the stomach and lengthen the esophagus and turn this little pouch into the new reservoir for food. This excised stomach right here is the fundus, and that's the craving center to what causes us to basically get hungry or crave foods. And then the duodenal switch, which is basically a combination of the sleeve gastrectomy and a long bypass. And this is usually reserved as a second part operation for a sleeve on patients who haven't really achieved the weight loss that they desired with just the sleeve alone. And so these are the minor complications of bariatric surgery. And if you compare this to these numbers, basically the safety profile of a gastric sleeve is about the same as a gallbladder surgery, which is the most common surgery we perform. Atelectasis is the most common complication. That's basically just patients who really weren't taking deep breaths and they just need a little bit of support, respiratory support over the first couple of days to help pop their lungs back open after surgery. Reflux is selectively just for the sleeves, and basically just creating that tubular structure of the stomach sometimes can increase reflux, not decrease reflux, although about 70% of reflux will improve with just weight loss alone because it decreases the pressure inside of our bellies, which decreases the pressure pushing the acid back up into our esophagus. And then these other minor complications are very low, wound infection, marginal ulcers, DVTs, stricture and hemorrhage. The most and anastomotic leak. Actually, the hemorrhage and anastomotic leak numbers are about 0.3% or 1 in 300. So we should probably update this because they're actually nationally lower than that. And the mortality risk is about 1 in 1,000, which is contrary to popular belief because bariatric surgery is very safe. This is our bariatric surgery data from August of 2023 to August of 2024, and you'll see that our numbers compared to national averages are similar or much lower than national averages for these complications. And I believe that can, again, be attributed to myself and Dr. Gerard performing surgeries in a very similar way and being very consistent with our outcomes. Long-term complications, and these things are more likely with gastric bypass than they are with sleeve, which is another reason why sleeve is the most popular surgery, is protein malnutrition. So basically, patients not able to take in as much because that pouch is smaller and they don't absorb food as well. And then vitamin deficiencies. And so it is important to stay on multivitamins long-term, more so with a gastric bypass than a gastric sleeve, although we encourage that with both. Expected weight loss after surgeries. This is the average expected weight loss. And so the EWL actually stands for excess body weight or excess weight loss. And so I like to explain basically sleeves and bypasses, you can expect to be about 70% of excess body weight loss after about 12 to 18 months after surgery. So when calculating excess body weight, basically, let's say that somebody's ideal body weight is 150 pounds. and let's say that they weigh 250 pounds, that's 100 pounds of excess body weight. And so losing 70 pounds would be what's anticipated as a national average for weight loss surgery results. We get generally the same weight loss in both a sleeve and a bypass. And I also tell patients that this is a database of hundreds of thousands of patients nationally and their average weight loss. And so that includes unmotivated patients and motivated patients, patients who are at the gym every day. And also includes, surgeons who are less talented and surgeons with great technique. So if you combine a motivated patient with a good surgeon, I think that patients can far exceed these numbers. Losing weight can help body function, improve ability to do things that are important to you. And so for results, and this is something that Greg touched on earlier, basically the resolution of comorbidities is one of the main reasons why insurance companies are so excited for patients to undergo bariatric surgery, because patients typically get healthier, come off of medications. And for patients, that's increasing lifespan. For insurance companies, that's decreasing the amount of money that they have to pay to take care of patients during their life. And so for sleep apnea, 75%, I think it's even higher than that. Sleep apnea will resolve with losing weight, so get off of that CPAP machine. Cardiovascular disease, the life expectancy as from a cardiovascular standpoint increases by 5 to 10 years after bariatric surgery. High blood pressure and high cholesterol resolve in almost every patient. Type 2 diabetes resolves with weight loss in 95% of patients coming off of insulin, coming off of metformin. Asthma improves, fatty liver disease improves, infertility, and patients can, younger patients who lose weight, who have polycystic ovarian syndrome and were basically declared infertile. I've seen some of those patients actually go on to get pregnant after losing the weight. And then osteoarthritis is a big one, and only 82%, and that's because patients wait so long before they get bariatric surgery. So they start having knee pain. They go to orthopedic surgeons who do injections and mask the knee pain while the knees are getting destroyed by traumatic forces, weight, forcing their weight on the joints, and that's eroding their joints over time, which is irreversible. And so the earlier patients lose weight, the less damage to the joints, and the lower likelihood that patients are going to go on the knee replacement or hip replacement surgeries. Another one that's not up here is breast cancer. About 50% risk reduction in breast cancer after bariatric surgery with losing weight, because obesity and breast cancer are so related. So surgery can help change your life. It improves or resolves obesity-related illnesses, as we talked about, and almost a 90% reduction in 5-year mortality. It reduces healthcare costs and utilization, which is why insurances love it so much. And it improves quality of life in 95% of patients. And again, we like to remind patients that surgery is just a tool. We do the easy part. Surgery is the easy part, and the patients do the hard part. And that's really staying with the program and staying motivated to go out, make their dietary changes, and stay in the gym and get healthier. So just more specifically about bariatric surgery at TMH, all is minimally invasive. Small incisions. We do all of these surgeries robotically. They're all under 2 hours. Bypasses average about 90 minutes. Sleeves average from 30 to 45 minutes. And so they're very, very quick. Like I said, we do the easy part surgeries. Patients typically stay 1 night in the hospital. And most are back to work in 1 to 2 weeks. But if patients need more time, we can give them more time. Because it is a big adjustment from pre-op to post-op in terms of learning how to reintroduce food. So for insurance information, and this is something that's important to get on the phone and talk to your insurance company about what's required prior to getting surgery and what benefits each individual policy has. Most of them require a BMI greater than 40 or greater than 35 with significant comorbidities, like Greg talked about. They do want a documented history of medical weight loss attempts for at least 3 to 6 months, and we get all of those visits with the metabolic center, seeing Greg, seeing dietitians a couple times, getting that psych eval, which is also required by insurance companies, and then seeing Greg again. That knocks off all of those check boxes for insurance, and then you come back and see us. A 5-year wait history is not required for every insurance company. There are a few that do. And again, it's important to just check with them on their requirements. And then nutritional counseling. So we're here to help you. We'll walk you through the process, we'll review your plan, and help make sure that you're a candidate your first visit. We submit documentation for you for insurance approval before starting the preoperative diets. And we provide examples of documentation required by insurance. That way the process is as easy as possible for you. And we do like to remind patients that active involvement, calling insurance companies and making sure they're aware that you're going through bariatric surgery, and making sure that you know exactly what you need for your policy is helpful. And then if you have any questions or concerns, Angie, who you saw earlier, is our program coordinator, and she's amazing, and she'll take all of your calls and talk to you for hours. But she's the glue that holds us all together. So that's it. We'll take any questions you have at this time. Thanks for coming. And then I will go check in with Angie and see if she has anything else that she wants to, oh, there she is, to share with y'all.
Anita says, thank you. Well, thank you, everybody, for joining us. Does anyone have any questions that they would like to ask Dr. Parker or Greg while we have them? Don't be shy. What is the level of pain?
So we've actually had a quality improvement project recently where we do local injections at the surgical site to help block the pain from the incisions, and probably 95% of our patients go home on just Tylenol on day one after surgery. And you know, if patients request pain meds, we give them to them, but patients don't even tend to request pain meds because the pain is so minimal.
Thank you, Dr. Parker. Looks like next we have another question about hormones. I think Dr. Parker may have answered the question, but it says, if I were interested in participating and hormones were an issue, would there be a referral to a specialist prior to the bariatric route? And what time frame on hormonal front is considered?
I think that would be really more specialized. Hormones kind of define a lot of different, you know, glands. You got thyroid. You've got, so we do have endocrinologists who work at that we have, you know, the ability to refer you to through TMH, who will be able to kind of address those issues. But like I said, you know, it's easy to say hormones are the cause, but it's a lot more challenging to find exactly what the cause is. And I wish I was specialized in that, and I'm not. But we'd be happy to have you see endocrinologists to kind of help pinpoint that down before we commit to surgery.
Thank you. And we have, how long is the process from consultation to surgery if surgery is needed?
Typically, you'll see us first in the surgery center, and we just go over surgical options. The reason being is because when we do this scheduling for the metabolic center through our clinic, it allows us to have that initial consultation, kind of basically start the hourglass for the insurance company. And then it allows us to order any preoperative testing that we would need to just make sure that you're a candidate. And that can take a month or two just to get that testing. So we like to do that up front. After that, then you go to the metabolic center for 4 visits once a month. Usually get referred back to see us once you've been qualified or finished your insurance pre-requirements, and that's usually 4 to 6 months after. So the total time is about 6 to 8 months from initial visit to surgery.
Does anyone have any other questions? Oh, absolutely. You are welcome. I want to thank you all for joining us tonight. We appreciate you listening to our webinar. Oh, we got one last question. Looks like, what is the size of the surgical incision?
I tell patients that it's 3 pinky size incisions and 1 thumb size incision.
All right, friends, it looks like our time is up. If you want to schedule a consult or need further information, please feel free to email me. You can call me. You can reach out to our offices. We would love to get you in and get you seen. I was going to do a couple of trivia questions, but I think we're just going to do a random selection. So be checking your email. There'll be 2 lucky winners for a Publix gift card, and I will reach out to you via the email that you used to register for our webinar. Thank you again. I appreciate you all joining us.
All right.
Hope
Thanks
you
for
all
coming.
have a good night.